So, very good afternoon, doctors. Here is Dr. Anil Timanayaka. I think last Sunday INI-CET exam got over. So, as per the review of many students, overall the quality of INI-CET exam this time is little bit tougher. But if you take OBG part, this time majority of the questions from OBG part is repeats of previous year INI-CET paper. Yes. So most of the questions are repeats of previous year INI-CET paper. And this time also examiner concentrated more on gynecology. Like 60 to 70% questions from gynecology and 30 to 40% questions from obstetrics. That too in gynecology, I yield topics. So I think the students who have attended my class, I used to tell some of the topics in gynecology like contraception, infertility, PCOS, amenorrhea topics. You will expect one or two questions from this topic. This year also the examiner concentrated more on these topics. Now dear doctors, here is a set of 18 to 20 questions from the recent INI-CET November 2021. So we'll discuss one by one. So the first question is from what? Emergency contraception. That is from the contraception topic. So emergency contraceptive used in India, that is the options are ethinyl estradiol 60 mg, levonorgestrel 1.5 mg, uliprostol 30 mg, misoprostol 600 microgram. The question is the emergency contraceptive which is supplied free of cost in India. And doctor, as a NEET PG aspirant from the contraception topic, emergency contraceptive topic is very high. You should know, yes, in and out of this topic. And dear doctors, here is a few points related to emergency contraceptive. Later we will come back to the question. So now doctor, this emergency contraception is also called as post-coital contraception, or it is also called as interceptives. So now dear doctors, we have got old method and we have got new method. Doctor, in old method, the old method which is we are using is use-P method. Use-P method, which is also called as morning after pills. Now doctor, we are not using this use-P method, which is the old method. Now we are using the new methods. What are all the new methods, doctor? That is levonorgestrel method. That is, we are using levonorgestrel. Now we will see what is the dose of levonorgestrel. Initially we will give 0.75 mg. After 12 hours, we will repeat the same dose, that is 0.75 mg. So total dose is 0.75 plus 0.75, that is 1.5 mg or 1500 microgram. Dear doctor, this levonorgestrel 1.5 mg or 1500 microgram is supplied free of cost by Government of India. And what is the program name? Easy Pill. Please make a note of it. What is the program name? Easy Pill. I think this is clear. So new method is levonorgestrel 1.5 mg, that is Easy Pill. Now what are the other drugs for newer methods? One is uliprostol, which is what? Selective progesterone receptor modulator, and centochromone. The drug is ormeloxifene and mifepristone, which is RU486, that is anti-progesterone, and copper IUC. These are all the drugs for emergency contraceptive in new methods. One is uliprostol, centochromone, mifepristone, and copper IUC. Yes. Doctor, one time they asked the dose of uliprostol also. It is 30 mg, but it is not supplied free of cost by Government of India. Yes. Now what is this use-P method? So use-P method is we are going to use oral contraceptive pills in the form of high dose pills or low dose pills. If you take high dose pills, 2 tablets 12 hours apart, another 2 tablets within 72 hours. If you take low dose pill, we will take 4 tablets 12 hours apart, another 4 tablets within 72 hours. So this is use-P method. So use-P method is oral contraceptive pills, and we are not using this use-P method. So we are using commonly this levonorgestrel method. And 3 important one-liners. Most effective hormonal emergency contraceptive is first effective is uliprostol, second effective is levonorgestrel. But overall most effective emergency contraception is copper IUCD. And most common method of emergency contraception overall is levonorgestrel. Overall most effective is copper IUCD. Overall most effective hormonal is uniprestal followed by levonorgestrel. So please make down these three important one-liners. Please they will ask you in the exam repeatedly. Now dear doctor, you make a note of it. That is contraceptives supplied free of cost by Government of India. One, Nirod. Nirod is nothing but what? Male condom. Please make a note of it. Nirod, that is which is supplied free of cost. That is male condom which is supplied free of cost by Government of India under the name what? Nirod. And Mala and that is OCPs. Yes. What is OCP? Supplied free of cost by Government of India under the name Malayan. And Antara that is injection DMPA. Yes, that is 150 mg intramuscular, and this is 3 monthly injection. So injection DMPA supplied free of cost by Government of India. What is the program name? Antara. And what is Chaya? That is nothing but centochromon. Please make a note of it. Centochromon. The pharmacological name is ormeloxifin. So centochromon, which is supplied free of cost by Government of India. What is the program name? Chaya. And Freedom 10 and Freedom 5. So Freedom 10 is nothing but copper T380A. Lifespan of copper T380A is 10 years. That's why Freedom 10. And Freedom 5 is multi-load copper 375. Lifespan of multi-load copper 375 is 5 years. That's why Freedom 5. So 380A is 10 years. That's why Freedom 10. And easy pill, I told you, tablet levonorgestrel 1.5 mg. Yes, this is a list of contraceptives which are all supplied free of cost by Government of India. As a NEET aspirant, please make a list of this and memorize. It's an IEL topic. Yes. So now come back to the question. Answer for this question. Emergency contraceptive used in India is what? Yes, levonorgestrel 1.5 mg. I think emergency contraception topic itself is cleared now. Yes. So please go on, look into this video, make the corner topics more familiar. Yes. So now another important question from the contraception topic itself. All are long-acting reversible contraceptives except. This is also repeat question. Dear doctor, this is also repeat question which is asked in the previous year INI-CET paper. So all are LARC except. Doctor, this LARC has got important two groups. So LARC is nothing but long-acting reversible contraceptives. LARC is nothing but what? Long-acting reversible contraceptives. So one, it can be Implanon, another one it can be IUCDs. IUCDs can be progesterone IUCD, which is LNG-IUS, that is Mirena, or copper IUCD. We have got two group of drugs for LARC. One is Implanon, another one is IUCD. IUCD can be progesterone IUCD or copper IUCD. Progesterone IUCD can be LNG-IUS, which is also called as Mirena, and copper IUCD. Now come back to the question. Among this, which is not a LARC? Yes, Implanon is a LARC. Copper IUCD is a LARC, LNG-IUS is a LARC, but laparoscopic tubal ligation is not a LARC. It is long-acting irreversible contraceptive. Yes. I think this question is clear. Okay, doctors. Now we'll come back to the question from infertility, that is especially the male infertility. Usually the questions can come from male infertility or female infertility, but surely one or two questions from infertility. Now look into the question. A couple complains of primary infertility in spite of staying together for 4 years and having unprotected intercourse. So in spite of staying together for 4 years and having unprotected intercourse, the couples are unable to conceive, and all tests of the wife are normal, and semen analysis report reveals azoospermia. And what is a diagnostic test that can distinguish between testicular failure and obstruction of vas deferens? The choices are estimation of FSH levels, testosterone levels, karyotyping, and FNAC of the testes. These are the options available. The question is very clear. Even after 4 years of unprotected intercourse, the couples are unable to conceive. All tests in the wife are normal, and some analysis shows azoospermia. The question is clear. Evaluation of azoospermia is a crystal clear question, and this is also repeat question. I'm telling you, this is also repeat question from the previous year. Yes. Doctor, just few quickly revise about the azoospermia, so evaluation of azoospermia. Doctor, if you all know, from hypothalamus the GnRH is released. Yes. Now this GnRH acts on anti-pituitary to release what? LH and FSH. Now this LH and FSH acts on testes. Yes, to release testosterone. Now this testosterone acts on male ductal system. Male ductal system includes what? Epididymis, vasa deferens, seminal vesicle, ejaculatory duct. And you all know, dear doctor, this serum testosterone has got negative feedback effect on GnRH. You got the point, doctor? Serum testosterone has got negative feedback effect on GnRH. Doctor, just for the sake of your knowledge, I will name this hypothalamus and anterior pituitary as pre-testicular pathway and testes as testicular pathway and this male ductal system as post-testicular. Now we'll come back to something happens to pre-testicular structures. What are all the hormonal defects? If something happens to testicular, what are all the hormonal defects? So we'll look into that. Now, if you take this pre-testicular azoospermia, that is something happens to hypothalamus and anterior pituitary, the GnRH will start decreasing. When GnRH decreases, LH also decreases, FSH also decreases, and testosterone also decreases. Here gonadotrophies like LH, FSH, GnRH, they are all low. That's why hypogonadism. You got the point? Whenever there is pre-testicular pathology, all hormonal profile will be low. Now come back to the testicular azoospermia. Whenever something happens to testis, the hormone which is released from testis is testosterone. So that hormone will decrease. Testosterone will decrease. When testosterone will decrease, what happens to GnRH, LH and FSH? Because the negative feedback effect on GnRH is lost. So GnRH will start increasing. When GnRH start will increasing, LH and FSH will increase. So your gonadotrophin levels are high. That's why it is hypergonadotrophic hypogonadism. I think so. In testicular defects, the gonadotrophins are high. In pre-testicular defects, gonadotrophins are low. And if you come for post-testicular, which is also called as obstructive azoospermia, all hormones are normal. That's why it is eugonadotrophic. Final take-home message: look, if all hormones are decreasing, it is pre-testicular azoospermia. If gonadotrophins are increasing, it is testicular azoospermia. If all hormones are normal, it is obstructive azoospermia, nothing but post-testicular. Among these hormones like GnRH, LH, FSH and testosterone, which is the one hormone which use it as a diagnostic test to differentiate between testicular and obstruction of vas deferens, is serum FSH. I told you, when serum FSH is decreasing, it is pre-testicular. If it is increasing, it is testicular. If it is normal, it is obstructive or post-testicular. And if you come back to the question, the answer for this question is estimation of FSH levels. Estimation of FSH levels. This is also a repeat question. Yes, I think you all clear this question. Yes. And this was not a repeat question. I think if you closely observe the choices, we can easily rule out. Yes, this question was once again taken from the infertility topic, that especially ovulation induction regarding the clomiphene citrate. All of the following are true statement regarding clomiphene citrate except. Dr. Clomiphene citrate blocks estrogen receptor at pituitary level. So you all know clomiphene citrate is a selective estrogen receptor modulator. Yes, it will block the estrogen receptors at pituitary level. It is a true statement. There is no doubt in that. And doctor, this clomiphene citrate causes monofollicular growth development, so less chances of multiple gestation. Yeah. So doctor, so as when you take the clomiphene citrate, it causes monofollicular. It won't causes multifollicular. That's why less chances of multiple gestation. And incidence of multiple gestation with clomiphene citrate is around 5 to 8%. It is less chance. So this statement also true statement. And when you give clomiphene citrate along with gonadotrophin, that better response is obtained. Yes, it is also true statement. It is also true statement. And the fourth statement, zooclomiphene is an active isomer. Doctor, this is a wrong statement. Zooclomiphene is not an active isomer. N-clomiphene, please make a note of it. N-clomiphene is an active isomer of what? Clomiphene citrate. Yes, I think this is clear. And final take-home message: incidence of multipretal gestation with clomiphene citrate. This was $1 million MCQ. It is 5 to 8%. It is 5 to 8%. Yes. So now we'll go back to the question number 5. I told you, in gynecology, one question. Yes, shortly you will get is amenorrhea, that is primary amenorrhea. Now, dear doctor, we'll go to look into this question. A mother brings her 18 18-year-old daughter. Age of the girl is 18 years. With a complaint that she has not started having menses. That is, it is primary amenorrhea. And her FSH, LH levels are normal. And general examination shows well-developed breast and pubic hair. That is, secondary sexual characteristics are present. So that is, general examination shows well-developed breast and pubic hair. That is, secondary sexual characteristic is present. On pelvic examination, vagina is blind ending and uterus is absent. And what is the diagnosis? I think this is a repeat, n number of repeats, same question. Understood? No? 18-year-old girl with primary amenorrhea with well-developed secondary sexual characteristics. On pelvic examination, absent uterus. What is the diagnosis? I think majority of the students knows this answer. Yes, well, before coming back to this question, just two things related to primary amenorrhea. Whenever a girl comes with primary amenorrhea, the first thing as a NEET PG aspirant, you should please look for or always examine for secondary sexual characteristics. Doctor, if secondary sexual characteristics are present, the next investigation is transvaginal sonography. Please make a note of it. Please look for secondary sexual characteristics. If secondary sexual characteristics are present, please order for transvaginal sonography, that is to rule out whether uterus is present or absent. Doctor, if uterus is absent, we have got two diagnoses. One is Mullerian agenesis, another one is androgen insensitivity syndrome. Please make a note of it. If secondary sexual characteristics are present, please go for TVS to know whether uterus is present or absent. If uterus is absent, we have got two diagnoses. One is Mullerian agenesis, which is also called as MRKH. Another one is androgen insensitivity syndrome, which is also called as testicular feminization syndrome. And if uterus is present, still there is no bleeding or no menses, that is hidden menstruation. What is it called as? Cryptomenorrhea. And most common cause for cryptomenorrhea is imperforate hymen. I think this slide is very clear. So whenever a girl with primary amenorrhea comes to you, please look for secondary sexual characteristics. If secondary sexual characteristics are present, then only go for TVS. In TVS, if uterus is absent, two diagnose. If uterus is present, that is cryptomenorrhea. Yes. And final take-home message. Doctor, if uterus absent but secondary sexual characteristics, doctor, please make it out. If uterus absent but secondary sexual characteristics present, doctor, if it is 46XX, it is Mullerian agenesis. If it is 46XY, it is androgen insensitivity syndrome. You got the point now? You have to remember this slide, doctor. It is most important slide. So if uterus absent, secondary sexual characteristics present, 46XX means Mullerian agenesis, 46XY means androgen insensitivity syndrome. If uterus present, secondary sexual characteristics absent, if it is 45XO, doctor, it is Turner syndrome. If it is 46XY, doctor, it is Swyer syndrome. I think this is very clear, doctor. So please look into this slide. If uterus absent, secondary sexual characteristic present, if it is 46XX, Mullerian agenesis. If it is 46XY, it is androgen insensitivity syndrome. If uterus present, secondary sexual characteristics absent, if it is 45XO, it is Turner's, and 46XY, it is Swyer syndrome. I think these two slides are clear. And if you come back to this question, doctor, I think you all know secondary sexual characteristics are present and uterus is absent. If it is 46XX, Mullerian agenesis. If it is 46XY, androgen insensitivity syndrome. Here it is not given, so most familiarly it is Mullerian agenesis. Because why, doctor? In testicular feminization syndrome, there is no pubic hair. Yes. Okay, doctors. Now we'll go back to the next question. Question number 6. This question appears to be a little bouncer in this exam. Approved guidelines for second stage of labor is, so 1, manual perineal support with fixed extension of fetal head. That is the one thing. Should be performed in lithotomy position. Episiotomy for all patients. Warm touching over lower abdomen. You got the point of what are all the approved guidelines for second stage of labor? One is manual perineal support with fixed extension of fetal head and should be performed in lithotomy position, episiotomy for all patients, and warm touching over lower abdomen. So few points. What are all the methods to be approved by WHO during second stage of labor or to prevent perineal tear? One. So one, no routine episiotomy. Please make a note. All women who are going for normal vaginal delivery, no routine episiotomy. No routine episiotomy. Then modified Ridgen manure. Please make a note. What is it? Modified Ridgen manure. Doctor, with right hand I will support the perineum, and with left hand will keep the fixed extension of fetal head. That is the one thing. You can all see the image, doctor. If you see this image, doctor, please make a note of it. This is the right hand. Doctor, this is the right hand. Yes, this is the left hand. Doctor, with right hand I am supporting the perineum, and left hand I am keeping the fixed extension of fetal head. Even you can see the image number 2 also. In the image number 2 also, doctor, so the right hand is used to support the perineum and left hand to keep the fixed extension of fetal head. And what is this manure, doctor? It is Ridgen manure. What is this manure? It is Ridgen manure. Please make a note of it. What is this manure? It is Ridgen manure. Yes, Ridgen manure is recommended by WHO during second stage of labor to prevent perineal labor. To prevent perineal tear. So no routine episiotomy, modified Ridgen manure. Yes, we have to perform modified Ridgen manure during second stage of labor to prevent perineal labor. And advise patient not to bear down while delivering the egg. These are all the recommendations given by WHO in the second stage of labor. You got the point? So no routine episiotomy, perform the modified Ridgen manure, and advise patient not to bear down while delivering the egg. Yes, and which is not recommended is routine episiotomy in all females undergoing vaginal delivery is not recommended by WHO. And final answer for this question is what, doctor? Manual perineal support with fixed extension of fetal head. What is that manure called as, doctor? Ridgen manure. What is that manure called as? Ridgen manure. Please make a note of it. Ridgen manure. I don't know. So right hand supports the perineum. Yes. Left hand keeps a fixed extension of fetal head. Yes. I think this question is clear. So now we'll come back to this. One of the question from preterm labor, that is anticipated preterm delivery. Dose of dexamethasone given to the mother is how much? Doctor, here is the dose of dexamethasone and betamethasone. Dexamethasone, it is a 6 mg, 4 doses, 12 hours apart. Yes, betamethasone 12 mg, 2 doses, 24 hours apart. This is also very repeat question. I am telling you, this is also, please make a note of it. This is also very repeat question. So dexamethasone is 4 doses, 12 hours apart, 6 mg. Option C is the correct option. Yes. Okay, doctor, is it clear? Yes. So now we'll go back to the next question number 8, which is a question from the Bishop's score. A primary para complains of lower abdominal pain at a period of 40 weeks 5 days. The fetus is in cephalic presentation. On examination, cervix is soft, posterior and 30% effaced. Cervix is soft, posterior and 30% effaced and 1 centimeter dilated, and station is -1. What is a Bishop's score? Doctor, please look into this. In the Bishop's score, we have got 5 components. One is dilatation, effacement, consistency, position and station. You got the point? 5 components for the Bishop's score. Dilatation, cervical components, 4 cervical components, another one fetal head component. What are the 4 cervical components? That is cervical dilatation, cervical effacement, cervical consistency, cervical position, and fetal head component, that is station. Now doctors, here cervical dilatation is 1 centimeter. So now the score is how much? 1. If for 1 centimeter cervical dilatation, score is 1. And effacement is 30%. So it is 0 score. And consistency is soft, means 2 score. Okay, doctor, consistency is what? Soft, 2 score. And position of the cervix is posterior, 0 score. And station is -1, that is 2 score. So come back to the question, doctor, once again. So now cervix is what, doctor? Soft is 2 score. Posterior is 0 score. 30%. Dear doctors, 30% effaced is how much it is? Once again 0 score. And 1 centimeter dilated is 1 score. And station of -1. Yes. How much it is, doctor? Station of -1. So let us see. Station of -1. Doctor, I think station of -1 is 2 score. Station of -1 is what? 2 score. Yes. Please look into this. So doctor, cervix is soft, that is 2 score, posterior is 0 score, 30% effaced is 0 score, 1 centimeter dilate is 1 score, station -1 2 score. Overall how much is 5? Yes, answer is option 5. Option 5 is the answer. Yes, please make a note of doctor. So these are all the components of the Bishop score. Cervical components 4 components and fetal head component, that is 1 component, that is station. And modified Bishop score, doctor, nothing different from the Bishop score, just cervical effacement. Please make a note of it. Cervical effacement is replaced. Cervical effacement is replaced by cervical length. That is a modified Bishop score. Okay, doctors. So now look into this. So in this cervical effacement here, it is replaced by cervical length. That is modified Bishop score. Yes. Yes. Okay, doctors. Double bleb sign in USG or defective of, it is also a repeat question. You all know it is amniotic sac and yolk sac. Double bleb sign, it is on USG, is always defective of amniotic sac and yolk sac. Yes. Now, this is also most of the repeat question. Yes. Many times question from Aschermann syndrome, expected question from Aschermann syndrome is clinical presentation of Aschermann syndrome. And you all know clinical presentation of Aschermann syndrome is hypomenorrhea. That is scanty menses. I think this is $1 million MCQ. All NEET PG aspirants should know this, the clinical presentation of Aschermann syndrome, that is hypomenorrhea or scanty menses. Doctor, Aschermann syndrome is also called as amenorrhea traumatica. Aschermann syndrome is also called as amenorrhea traumatica. It is a secondary amenorrhea. Please make a note of it. Aschermann syndrome never caused primary amenorrhea. It always caused secondary amenorrhea due to intrauterine synechia. Here endometrium is defective. So few important one-liners. Most common causes vigorous curate charge. Most common presentation is hypomenorrhea, which is also called as scanty menses, followed by secondary amenorrhea. And investigation of choice is hysteroscopy. And management is hysteroscopic adenosis plus cyclical OCPs, because your endometrium is defective. We have to rebuild the endometrium. That's why we have to give cyclical OCPs. You got the point? Aschermann syndrome, 5 golden points should be in the tip of the tongue. 1, most common causes vigorous curate charge. Most common presentation is hypomenorrhea. Investigation of choice is hysteroscopy, and management is hysteroscopic adenosis with cyclical OCPs. And intrauterine synechia means Aschermann syndrome. Yes. Okay, doctor. The question number 11. What is the instrument used here? I think majority of them know this. This is Cusco's bivalve self-retaining. That is the main difference between Sim speculum and Cusco speculum. Bivalve self-retaining Cusco speculum. Yes. Okay, doctors. Now we will go back to the next question, which is a question from the endometrial CA, that is gynec oncology. A 60-year-old female who attained menopause 2 years back. Now she came with history of post-menopausal bleeding, and she is non-diabetic and non-hypertensive. What is the diagnostic test? So 2 years back, a 60-year-old who had got menopause, who had attained menopause, now she complains of post-menopausal bleeding and no comorbid, no diabetes, no hypertension. What is a diagnostic test? Doctor, whenever a patient comes with post-menopausal bleeding, always go for transvaginal sonography. Why, doctor? Please, to check for the endometrial thickness. Please make a note of it. To check for the endometrial thickness, we'll go for transvaginal sonography. WHO recommends endometrial thickness of 4 mm and FIGO recommends endometrial thickness of 5 mm. WHO recommends endometrial thickness of 4 mm and FIGO recommends endometrial thickness of 5 mm. If it is more than 4 mm or more than 5 mm, it requires evaluation. If endometrial thickness is less than 4 mm, just review the patient after 3 months, or earlier can be reviewed if there is bleeding. And if it is, doctor, if it is more than 4 mm with diffuse thickness, that is homogeneous thickness, more than 4 mm with diffuse thickness or homogeneous thickness, investigation of choice is endometrial aspiration biopsy by either Pipple or DNC or Vabra aspirator. But gold standard, histoscopy guided biopsy. You got the point? Homogeneous thickness, investigation of choices, endometrial aspiration biopsy, gold standard is histoscopy. But focal areas of thickness, investigation of choices, histoscopy, gold standard also histoscopy. You got the point, doctor? For homogeneous thickness, investigation of choice is endometrial aspiration biopsy, gold standard is hysteroscopy. For focal areas of thickness, investigation of choice is hysteroscopy, gold standard also hysteroscopy. Now, doctor, what is this homogeneous thickness and focal areas of thickness means? Nothing but, doctor, look into this. So homogeneous thickness. So this is the homogeneous thickness. Look into this. This is the homogeneous thickness. Please make a note of it. This is the homogeneous thickness. This is the homogeneous thickness. That is diffuse thickness. Homogeneous thickness. Okay, doctor. This is the homogeneous thickness. Now, next, which is the focal areas of thickness. See, this is the focal areas of thickness. Like polyp. This is the focal areas of thickness. So this is a focal areas of thickness. Okay, I think this image is very clear. Focal areas of thickness. Homogeneous thickness, investigation of choices, endometrial aspiration biopsy. Endometrial aspiration biopsy. And what is the gold standard, dear doctor? Gold standard, yes, it is hysteroscopy. Hysteroscopy. But focal areas of thickness, investigation of choice and gold standard both are same. Investigation of choice and gold standard both are same. That is hysteroscopy. Hysteroscopy. Yes. Yes, I think this is clear. This is also repeat question. Repeat question. Please make a note of it. This is also repeat question. Answer here is, doctor. Yes, we have to go for endometrial sampling by endometrial aspiration biopsy or endometrial what? Biopsy. Yes. Yes, I think this is clear. No, homogeneous thickness and diffuse thickness. Homogeneous thickness is nothing but diffuse thickness. Yes, yes. Question number 13. According to WHO classification of ovarian tumor, clear cell carcinoma ovary belongs to epithelial, sex cord, germ cell, metastatic. I think majority of them answered correctly. Yes, clear cell carcinoma always belongs to epithelial tumors. Clear cell carcinoma always belongs to what? Epithelial tumors. Doctor, here is the WHO classification of ovarian tumors. So, epithelial ovarian tumor, germ cell tumor, sex cord stromal cell tumor and metastatic tumor, which is called as Krukenberg tumor. Krukenberg tumor. Among these four, the first most common ovarian tumor overall is epithelial, followed by germ cell. Followed by germ cell. So epithelial ovarian tumors, germ cell, sex cord and metastatic tumor. Now we look into the epithelial ovarian tumor. One is serous cystadenoma, that is benign. Malignant variety is serous cyst adenocarcinoma. And mucinous cystadenoma, that is benign. Malignant counterpart is mucinous cyst adenocarcinoma. Endometrioid, Brenner, clear cell undifferentiated. You know, no? The clear cell tumor belongs to what? Epithelial. Okay, yes, and most common benign, doctor, most common benign epithelial ovarian tumor is serous cystadenoma. Most common benign epithelial ovarian tumor is serous cystadenoma. Now come for the germ cell tumor. So benign variety, malignant variety. Benign variety, that is mature cystic teratoma, which is also called as dermoid cyst. And malignant variety, we have got immature teratoma, yolk sac tumor, which is also called as endodermal sinus tumor, choriocarcinoma, dysgerminoma, embryonal carcinoma. And most common benign germ cell tumor is what? Dermoid. And most common malignant germ cell tumor is immature teratoma. Previously it was dysgerminoma. Now immature teratoma is taken over the dysgerminoma. Yes, these are all the germ cell tumors. And sex cord stromal tumors, these are all the tumors which secrete male or female hormones. If it is estrogen secreting and androgen secreting. Doctor, please make a note of it. These are all androgen secreting. Please make a note of it. These are all androgen secreting and these are all estrogen secreting. Please change yourself. These are all androgen secreting and estrogen secreting. Androgen secreting tumors are Sertoli, Leydig and islet cell. Estrogen secreting granulosa, theca cell and fibroma. You got the point, doctor? Please make a change of this. Androgen secreting ovarian tumors are Sertoli cell tumor, Leydig cell tumor and islet cell tumor. Okay? Yes. And estrogen secreting ovarian tumor or granulosa cell tumor or thecoma and fibroma. Yes. This estrogen secreting, that is granulosa, thecoma, fibroma, they are all feminizing ovarian tumors. Please make a note of it. Yes. Okay, doctors, I think this is clear. So among this, clear cell tumor belongs to what? Epithelial tumors. Epithelial tumors. Yes, yes, I think this question is very clear and simple. Okay, now come back to one of the question from PPH. Dose of carbetocin. This is also repeat. Doctor, uterotonics is the most expected question from the PPH topic. We'll come back to the dose of the carbetocin. Few things we'll discuss uterotonic, which are all WHO recommended. The first line, doctor, you all know the first line uterotonic is always oxytocin. The starting dose is 10 units. IM or IV infusion, never IV bolus. We should never give oxytocin direct IV because it causes hypotension, sudden hypotension and cardiac arrest. This was $1 million clinical question. Yes. So never IV bolus. Oxytocin should never be given IV bolus. It causes sudden hypotension and cardiac arrest. And start dose is 10 units. IM or IV infusion, never IV bolus. And second line is ergot alkaloids, that is ergometrin, or methyl ergometrin, that is methergin. And start dose is 0.2 mg IM or IV, that is 0.2 mg every 4th hourly for 5 doses. And what is the maximum dose, dear doctor? Maximum dose is 1 mg. Maximum dose is 1 mg. Understood, doctor? I think this is clear. First line is oxytocin, second line is ergot alkaloids, which includes ergometrin or methergin, which is also called as methyl ergometrin. Third line is prostaglandins. We have got two prostaglandins. One is 15 methyl PGF2 alpha, which is also called as carboprost or dinoprost. Carboprost is also called as dinoprost or 15 methyl PGF2 alpha, and PG even, that is misoprostol. Doctor, so start dose of carboprost, please make a note of it. Start dose of carboprost is 250 microgram intramuscular, and maximum dose is 8 doses, that is 250 into 8, that is 2000 microgram or 2 mg. This was a NEET PG 2020 question. Yes, maximum dose of carboprost they are asked. It is 8 doses. Start doses 250 microgram. 8 doses means 250 into 8, that is 2000 or 2 mg. Yes, yes. And PG even, that is misoprostol. For prevention it is 600 microgram orally. For treatment of PPH it is 800 microgram sublingually, and per rectally we can keep 800 to 1000 microgram. Is it clear? Doctor, two prostaglandins, one is PGF2 alpha, another one is PGE1. PGF2 alpha is also called as carboprost or dinoprost. Doctor, another one entity is there, that is dinoprostone. This is PGE2, which is used for induction of labor. Dinoprost is carboprost. Yes, yes. Next, doctor, others which are also WHO recommended, that is symptometrin, which has got fixed dose combination of oxytocin and methyl ergometrin, and carbetocin, that is 100 microgram IV, and injection tranexamic acid 1 gram IV infusion. Injection tranexamic acid 1 gram IV infusion. These are all the drugs recommended by WHO. One is symptometrin, which is a fixed dose combination of oxytocin plus methyl ergometrin, and carbetocin, which is a dose of 100 microgram IV, and tranexamic acid 1 gram IV. And come back to this. What is the dose of carbetocin, doctor? Yes, 100 microgram. Yes, yes. Carbetocin dose is 100 microgram. Yes, yes. Okay, doctors, we'll discuss the next question. Yes, it is a question from the molar pregnancy. A 36-year-old gravida 1 para 0, that is primary gravida woman, presents for the first prenatal visit in 12 weeks of pregnancy. She complains of persistent vaginal bleeding, nausea and pelvic pain. Yes, nausea and pelvic pain. Physical examination is notable for gravid uterus more than for gestation age. Gravid uterus larger than expected for gestation age, and USG shows below findings. What is the diagnosis? Doctor, she is 12 weeks, but on clinical examination it appears more than gestational age. Means it maybe appears 16 weeks or 20 weeks. And you all can see this classical appearance of fluid filled chorionic villi. On USG, doctor, these fluid filled chorionic villi appears like snowstorm appearance. Snowstorm appearance. And doctor, you all know snowstorm appearance is a characteristic of identiform mole. Snowstorm appearance is a characteristic of what? Identiform mole. Yes, yes. Doctor, here is a few points. When you expect fundal height more than POG, that is, if gravid uterus, dear doctor, if gravid uterus is more than the period of gestation, means if she says 6 months, on clinical examination it is 9 months, what are all the DDs you will expect? One is wrong dates, full bladder, multiple pregnancy, polyhydramnios, big baby, vesicular mole, that is identiform mole, or pelvic tumors complicating pregnancy like ovarian or fibroid. Yes, these are all the DDs for gravid uterus more than POG. One DD, important DD, yes, wrong date. You should inquire from the mother whether her LMP is reliable or not. Then you should examine the mother after emptying the bladder. Multiple pregnancy, polyhydramnios, big baby, vesicular mole, pelvic tumors complicating pregnancy like ovarian or fibroid. Next, fundal height less than POG, that is gravid uterus less than POG. Once again, please rule out wrong dates. Yes, inquire from the mother whether her LMP is reliable or not. Then oligohydramnios, transverse line, intrauterine fetal demise, fetal growth restriction, missed abortion or delayed conception in case of irregular periods. These are all the DDs for fundal height less than POG. One is wrong dates. Yes, oligohydramnios, transverse line, intrauterine fetal demise, fetal growth restriction, missed abortion, delayed conception in irregular periods. Yes, yes. Doctor, in this question, yes, fundal height is more than POG, and characteristic USG image, that is snowstorm appearance. Snowstorm appearance. Yes, yes. Now, doctor, next question. Figure shows 22-year-old female complaining of irregular cycles with hirsutism. Irregular cycles with hirsutism. USG revealed multiple cysts in both ovaries with 14 cc volume. What are all the preferred treatment options? Like OCPs we can use, GnRH agonists or danazole, lifestyle modification, laparoscopic drilling of the what? Laparoscopic drilling of cyst. Yes, so the image is, we can see airy growth over the chin and neck. Yes, we all can see, we can see the hairy growth over the chin and neck, that is hirsutism. Hirsutism is nothing but excessive growth of androgen dependent sexual hair. Understand? Hirsutism is nothing but excessive growth of androgen dependent sexual hair. Understood? No? So now here they are asking for the treatment for hirsutism. Doctor, you all know first and most effective treatment for hirsutism is OCPs. Next, followed by medroxyprogesterone acetate. Then what are the others is spironolactone, cyproterone acetate, flutamide, finasteride, GnRH agonist, and topical eflornithine hydrochloride. Doctor, this flutamide and finasteride, they are all anti-androgenic drugs, because hirsutism is already hyperandrogenic state. So we should use the drugs which are anti-androgenic or least androgenic. That's why, so first and most effective treatment for hirsutism is OCPs. This was $1 million MCQ. What are the other drugs for hirsutism? Medroxyprogesterone acetate, spironolactone, cyproterone acetate. Then flutamide, finasteride, GnRH agonist, and topical eflornithine hydrochloride. Yes, OCPs also we can use GnRH agonist, lifestyle modification, laparoscopic drilling of cyst, but not danazole. Danazole is androgenic drug. Danazole is androgenic. Hirsutism is already hyperandrogenic state. We can't add androgenic drugs. So danazole is not used in the treatment of hirsutism. So option 3, yes, this is also not, this is also. So either option A or D. Most preferable is option D. Option D. Yes, yes. I think this question is clear. Okay, doctors, 1 minute. So I think this question is very clear. So you should know, as a NEET PG aspirant, the list of drugs used in the management of hirsutism. Now come back to the ovarian tumor with their tumor markers. This is a multiple choice question. So they are linking dysgerminoma as a LDH, yolk sac tumor is a alpha fetoprotein, granulosa tumor inhibin, serous cystadinoma carcinoma embryonic antigen, choriocarcinoma beta SHA. Before knowing this question, we look into the tumor markers. What is the main tumor marker? What are the other tumor marker? And what this tumor never produces? Doctor, you all know serous cystadinoma main tumor marker is CA125, and mucinous cystadinoma main tumor marker is carcinoma embryonic antigen, and others is CA199. And dysgerminoma main is LDH. Others are HCG and placental alkaline phosphatase. And dysgerminoma never produces alpha fetoprotein. And yolk sac tumor, which is also called as endodermal sinus tumor, main tumor marker is alpha fetoprotein. And other tumor markers for yolk sac tumor is one is LDH, another one is alpha antitrypsin. And this yolk sac tumor never produces HCG, never produces HCG. And choriocarcinoma, yes, main tumor marker is HCG. Serous cystadenoma CA125, mucinous cystadenoma, carcinoembryonic antigen, and others are CA199. Dysgerminoma main is what? LDH, others is placental alkaline phosphatase and HCG. And dysgerminoma never produces alpha fetoprotein. And yolk sac tumor mainly is alpha fetoprotein, others is LDH and alpha antitrypsin, and never produces beta HCG. And choriocarcinoma, yes, beta HCG. Dysgerminoma LDH, yes, true. Yolk sac tumor, alpha fetoprotein, yes, true. Granulosa cell tumor, yes, indipin is a main tumor marker. Serous cystadenoma CA125, it is a false option. Choriocarcinoma, beta HCG, yes, true. Only fourth option is false. So fourth option, wherever 4, yes, this is 4, we can't take. This is 4, we can't take. So 1 and 4, 1, 2, 3. Yes, we'll go for 1, 2, 3 is more preferred than option A. Yes, yes. Last question, doctor. We'll come back to this question, which is a question from the vaginal infection. A 26-year-old girl visits to gynecology OPD with a history of greenish vaginal discharge. On perspiculum examination, strawberry cervix is seen. What is this treatment of choice? I think strawberry cervix, strawberry vagina. Yes, it is a characteristically seen of trichomonas vaginitis, and all of you all know the drug of choice for trichomonas vaginitis is metronidazole. Yes, yes. Doctor, just 5 to 6 golden points regarding this bacterial vaginosis and candidiosis and trichomonas vaginitis. Just golden points. Just we will revise before ending this session. My humble request. Doctor, organism is Gardnerella vaginalis. For bacterial vaginosis, the organism is Gardnerella vaginalis, and the organism for candidiasis is Candida albicans, and the organism for trichomonas vaginitis is Trichomonas vaginalis. Yes, and doctor, you should know most common vaginitis overall is bacterial vaginosis, and most common vaginitis in pregnancy or diabetic patients or OCP users or antibiotic users or steroid users, it is always candidiasis. Please make a note. Overall most common vaginitis is bacterial vaginosis, and overall vaginitis in pregnant woman or diabetic woman or OCP users or antibiotic users or steroid users is candidiasis. And doctor, among these three, which is not an STD is bacterial vaginosis, which is an STD is trichomonas vaginitis. Please make a note of it. Which is not an STD is bacterial vaginosis, which is an STD is trichomonas vaginitis. That is sexually transmitted disease. Sexually transmitting disease. And pH of bacterial vaginosis is more than 4.5, and pH of candidiasis is less than 4.5. That's why this is the one vaginitis which is seen in acidic media, and pH is 5 to 6. 5 to 6. So please make a note of pH more than 4.5. Yes, bacterial vaginosis. pH less than 4.5 candidiasis. 5 to 6 trichomonas vaginitis. And characteristic presentation of bacterial vaginosis is foul smelling, dirty white discharge. Dirty white discharge. And there is no inflammation. That's why there is no itching. Foul smelling, dirty white discharge. Yes, and doctor, what is the presentation of candidiasis? It is a curdy white discharge associated with intense pruritus. Intense pruritus. Yes, yes. Now, what is the presentation of trichomonas vaginitis? It is profuse, frothy, greenish yellow discharge. Doctor, please make it a foul smelling, dirty white discharge is bacterial vaginosis. Curdy white discharge with itching is candidiasis. Profuse, frothy, greenish yellow discharge is trichomonas vaginitis. You got a point now? So foul smelling, dirty white discharge without itching is bacterial vaginosis. Curdy white discharge with itching is candidiasis. Profuse, frothy, greenish yellow discharge is always trichomonas vaginitis. And doctor, the signs, the characteristic sign for trichomonas vaginitis is strawberry cervix or strawberry vagina, and there is no specific signs for bacterial vaginosis or candidiasis. And doctor, investigation of choice for all the three is saline microscopy, saline microscopy, saline microscopy. And here doctors, doctor, for this bacterial vaginosis on saline microscopy, you are going to see closed cells. Closed cells. What is it? Closed cells? That is vaginal epithelial cells, which is to which the bacteria is adherent. And to this Vaginal epithelial bacterial cells are adherent, that is clue cells. And in candidiasis on saline microscopy we are going to see pseudo-hyphae. And for trichomonas vaginitis on saline microscopy you are going to see flagellated protozoa. So investigation of choice is saline microscopy, saline microscopy, saline microscopy. Clue cells, bacterial vaginosis, pseudo-hyphae, candidiasis, flagellated protozoa, what? Trichomonas vaginitis. And gold standard for bacterial vaginosis is gram strain. Candidiasis is culture on subarodes or Nickerson media. And gold standard for trichomonas vaginitis is Feinberg-Whittington media or diamond media. Yes, and doctor, one of the important tests, that is amine test or whiff test. What is this amine test or whiff test? If you add 10% to the vaginal discharge, if you get fishy odor, that is amine test or whiff test is positive. Doctor, amine test or whiff test positive, always characteristic of bacterial vaginosis. You got the point? What is this amine test or whiff test? If you add 10% KOH to the vaginal discharge, if you get fishy odor, understand, or amine like odor, yes, it is, whiff test is positive or amine test is positive, which is characteristically seen in bacterial vaginosis, but it is not seen in candidiasis or trichomonas vaginitis. And doctor, final take home message, treatment of choice for bacterial vaginosis is metronidazole. Candidiasis, that is azole group of antifungals, that is fluconazole or matinozole, and antibiotic of choice for trichomonas vaginitis is metronidazole. And doctor, in bacterial vaginosis and candidiasis, no treatment of partner is required. But trichomonas vaginitis, yes, it is an STD. It is an STD. Yes, treatment of partner is required. Yes, I think this is clear, doctor. Please make a note of it. Clue cells, whiff test positive, pH more than 4.5. Yes. They are all characteristically seen in what? Bacterial vaginosis. Doctor, there is one important criteria, that is Amsler's criteria. Amsler's criteria for bacterial vaginosis. One, that is pH more than 4.5. Please make a note of pH more than 4.5. And clue cells on wet film preparation, that is saline microscopy. And another one, doctor, amine test positive. Amine test positive or whiff test positive. Yes, what is this amine test or whiff test? On adding 10% KOH to the vaginal discharge, if you get fishy odor, yes, it is what? Whiff test. Okay, doctor, I think you're all happy with today's discussion of 18 questions of OBG from the November INI-CET exam. Doctor, please look into the video. Some of the topics are discussed in detail, and I try to cover maximum questions which have appeared in the last Sunday's INI-CET exam. Anyway, doctors, thank you. Please follow my YouTube channel, Telegram channel for updates for NEET PG 2022 exam. Thank you, doctors. All the best. God bless you. Thank you.